Hi, my name is Arzu Farhangi and I'm presenting a case titled Anterior Spinal Infarct, Diagnosis and Management of a Rare Cause of a Stroke. A spinal cord infarction is rare and represents a diagnostic challenge for many physicians. There are few reported cases worldwide with a prevalence of 1.2% of all strokes. Circulation to the spinal cord is supplied by a ridge anastomosis. The anterior spinal artery supplies the anterior two-thirds of the spinal cord, and infarction of this area is marked by paralysis, spinothalamic sensory deficit, and loss of sphincter control, depending on where the lesion is. Treatment of a spinal cord infarction focuses on rehabilitation with diverse outcomes. This report presents a case of acute spinal infarction with acquisition of MRI to aid our diagnosis. The case is an 80-year-old female with a past medical history significant for hypertension, coronary artery disease, carotid endarterectomy, and COPD. She presented to the emergency department with sudden onset of low back pain, bilateral leg weakness, saddle anesthesia, and urinary incontinence. She denied any fever, fall, recent travel, or any vaccination. On physical exam, her blood pressure was 190/89 and her heart rate was 70 beats per minute and regular. Lower limb examination demonstrated a flaccid paraparesis with a power of 0 out of 5 with absent deep tendon reflexes. Sensory modality of pinprick and temperature were impaired below the level of T10, but vibration, touch, and proprioception were intact. The remainder of the examination was unremarkable. Given the extensive history of cardiovascular disease, the differential included cord infarct and less likely infectious and inflammatory myelitis. Emergent MRI showed increased signal intensity within the anterior gray matter of the T2 weighted images from T12 through the conus, suggesting an acute vascular event to the spinal cord. Inflammatory and infectious etiologies were ruled out via CSF studies. Patient was started on a steroid pulses therapy for 5 days and dual antiplatelet and a statin. Patient was discharged to continue short-term physical rehabilitation. In discussion, this case report highlights the spinal cord infarction is sudden in onset, dramatic incapacity, and frequently disabling. A vascular event involving the anterior spinal artery was evident in this case following exclusion of compressive causes and history of atherosclerosis. Together with the MRI confirmed that the diagnosis and the extent of the damage. The clinical picture primarily depends on the location of the occlusion. It may accompany back pain that radiates down to the legs and loss of sphincter control. The acute stage may last for several days and is marked by initial flaccid paralysis, absence of these different reflexes, and sensory level distal to the lesion where the pain and temperature are not perceived. Over time, there is increased muscle tone and reflexes become hyperactive and Babinski becomes positive. Proprioception and vibration are usually intact as they are supplied by the dorsal columns. Diagnostic challenges are attributed by the vast number of differential diagnoses which can mimic a spinal infarction, which including Guillain-Barré syndrome, transverse myelopathy, or mass lesion effect. MRI is sensitive and reliable modality of the diagnosis. It can show signal changes and swelling of the cord within just a few hours of onset. Treatment focuses on risk factor and rehabilitation. As the most causative agent is atherosclerosis, treatment with antiplatelet therapy is fundamental. And if the source is judged to be embolic, then anticoagulation should be started. Also, some studies have looked at corticosteroid therapy administered within a short time of following a spinal infarction due to protective effect on the cell function and reducing oxidative stress following the ischemic injury can be useful. Thank you so much for your attention.